Hello, I am Tracey Cho, clinical professor of neurology and director of neuroimmunology at the University of Iowa. I have been caring for patients with NMO for more than 12 years now. I do have a disclaimer before I give this talk on optic neuritis, and that is that I'm a neurologist and not a neuro-ophthalmologist. I also have the distinction and privilege of being Sumaira's first neurologist, and I would like to thank her for all that she has done to bring focus to NMO and related diseases, and for giving me the opportunity to speak to you all today. I am pleased to be speaking on optic neuritis on behalf of the Sumaira Foundation for NMOs from the Experts Facebook Live series. For those that may have tried to join last week, I apologize for my technical difficulties, and hopefully the session will run smoothly today. This programming is made possible thanks to a patient education grant from Horizon Therapeutics. Horizon Therapeutics is committed to delivering medicines for rare, autoimmune, and severe inflammatory diseases, and providing compassionate support comes from their strong and simple philosophy to make a meaningful difference for patients and communities in need. Their approach to drug discovery is aimed at providing targeted treatments for improved outcomes for the thousands of patients who have few or no therapeutic options. For additional information about Horizon Therapeutics, please visit www.horizontherapeutics.com. For today, I will start by discussing the optic nerve and its place in the nervous system. Then I will explain the process by which the optic nerve is injured in optic neuritis. I will review the symptoms and examination signs that result, as well as the testing that can help confirm a diagnosis of optic neuritis. Finally, I will touch on some of the specific diseases that cause optic neuritis and the initial approach to treatment. I will leave some time for questions in the last 25 minutes or so, and I will try to address any questions that come up during my initial presentation as well. So, what is the optic nerve? First, let's talk about the retina. The retina is the organ at the back of the eye that receives light and serves as the sensor for vision. It is connected to the brain through the optic nerve. And the nerve itself is made of a central conducting part called the axon, and the insulation around it called the myelin. Because the retina is biologically part of the central nervous system, the optic nerve is insulated by the same type of myelin as other parts of the brain and spinal cord. Diseases such as NMO, MOG-associated disease, and multiple sclerosis that affect central nervous system myelin frequently involve the optic nerve because it is a long nerve with a lot of insulation around it. So why does optic neuritis happen, and how does the injury occur? A combination of genetic and environmental factors leads to an inflammatory attack on the myelin of the optic nerve. White blood cells that are the main part of your immune system travel through the blood to the optic nerve and inappropriately attack the myelin, thinking of it as a threat to be targeted like an infection. So it's kind of like friendly fire. The white blood cells release chemicals that damage the optic nerve and cause swelling. This inflammation can also sometimes damage the axon or the wire underneath the insulation. What symptoms do patients have when they get optic neuritis? So the most common symptoms are decreased vision and pain in the eye. The decreased vision, or what we see on exam as visual acuity, comes on over hours and sometimes days, and it generally takes days to weeks to reach its worst point. So this isn't something that typically comes on over minutes or hours, although there is a variability in that regard. Almost all patients also have pain in the same eye that is affected by the decreased vision. the pain is typically worsened when a patient looks in either direction. So eye movements make the pain worse. That is just a mechanical thing because the optic nerve is inflamed, and when you move your eye, it stretches the nerve. Most cases of optic neuritis affect only one eye, but in certain diseases such as NMO and MOGAD-associated disease, both optic nerves can be involved at the same time. Other symptoms are variable, and not every patient will experience them. Some patients with optic neuritis will have a flickering or a flashing of light. Many patients have an impairment of color vision, so deep reds appear more orange or faded. When you see a doctor, things that we look for on examination with optic neuritis include a difference in how the pupil responds. An abnormal pupil response called an afferent pupillary defect is quite common with optic neuritis, as long as one of the optic nerves is normal. So this is an abnormal response in the affected eye that is brought out because of the normal eye that is still transmitting light. Visual field testing is something that can also be abnormal in optic neuritis, and it typically involves decreased vision in the middle part or central vision, although there are variations and some patients have more peripheral vision affected as well. A doctor can look in the back of the eye with an ophthalmoscope, and with the acute optic neuritis, sometimes we can see swelling and inflammation where the nerve meets the retina. Color vision is also something that can be formally tested. So in addition to patients' experience with color, this can be formally tested with special cards or with other specialized tests. Some of these exam findings can persist even after a patient recovers from optic neuritis. And this is important when looking for any evidence that someone has had optic neuritis in the past. Often there's a difference in the vision between the two eyes. So when you do visual acuity testing with reading the numbers or letters on a chart, one eye is better than the other. The afferent pupillary defect or difference in the pupil response that I mentioned earlier, that can persist even after the vision recovers. And then when the doctor looks in the back of the eye in someone who's had optic neuritis a long time ago, instead of seeing swelling, you can see a pale and a shrunken optic nerve in the back of the eye. In addition to the patient's experience and what we find on exam, there are tests that can help confirm the diagnosis. I will say that just listening to a patient's symptoms and knowing how quickly it came on, combined with an examination, is most of what you need to make a diagnosis. These tests that I'm going to go through now are more to confirm what you're already suspecting based on what the patient has experienced and what you do on your examination. So all patients should undergo formal ophthalmology examination. Even though neurologists often look in the back of the eye, we don't have all the special tools that are available in an ophthalmology office. In addition to that, almost all patients should have an MRI focused on the orbit as well as the brain. And this should include contrast dye. And this can look for signs of inflammation in the optic nerve, as well as signs of other prior or current episodes of inflammation elsewhere in the brain, such as what we see in multiple sclerosis. Some patients, in addition, should also have an MRI of their entire spinal cord to look for signs of prior or current myelitis or inflammation of the spinal cord. This is obviously important in NMO, as the name neuromyelitis optica suggests. It often involves both the spinal cord and the optic nerves. Blood tests for aquaporin 4 and MOG IgG should essentially be done in all patients these days with optic neuritis. And this has become fairly standard whenever we see patients who have an indication of optic neuritis. Some patients may require a spinal tap to assess for unusual causes or to help confirm a diagnosis of multiple sclerosis. Patients who clearly have NMO don't necessarily need to have a spinal tap, but we often don't know that at the time that they present with their first episode. Other blood tests and spinal fluid tests may be necessary depending on the situation and just varies from patient to patient. A test called optical coherence tomography, or OCT, is usually performed during ophthalmology exam. This test measures the thickness of the retina and can be very useful to detect optic neuritis. Because there's often swelling early in a patient's experience with optic neuritis, this test is often more useful later after some of that swelling has resolved. Another test that we don't use as much anymore, but can still sometimes be helpful, is something called visual evoked potentials, or VEP. Sometimes it's called a visual evoked response. In this test, the patient is shown different images of black and white squares, and electrodes are placed on the back of the head over the vision area of the brain to measure how fast the signal reaches that part of the brain. It's an indirect way of measuring how well your optic nerves are transmitting that signal. And particularly when there's a difference between the two sides, it can be useful to diagnose prior optic neuritis. It's not typically something we use in acute situations. Now that we've talked about the symptoms and the diagnosis of optic neuritis, I wanted to talk briefly about treatment and the diseases, specific diseases that can cause optic neuritis. So for almost all patients, intravenous corticosteroids are going to be given when you are diagnosed with optic neuritis. And that's because these medicines work quickly to reduce inflammation, and they can speed up the recovery process. There's not a lot of great evidence that they change the ultimate recovery or how well your vision recovers after optic neuritis, but it definitely can help that recovery happen faster. For patients who have severe optic neuritis, or where they have optic neuritis involving both eyes, and those patients who don't respond to that initial intravenous corticosteroid treatment, plasma exchange is often performed, particularly in larger centers that have access to this. This is basically a treatment in which a patient's blood is pulled out through a vein. It is washed to remove antibodies, including unwanted antibodies and other chemicals that can contribute to inflammation. And then the plasma is put back into a patient through another IV line. This requires a lot of expertise and staffing power from technicians who operate the machine. But for patients who are at risk for losing their sight, it's something that can sometimes be helpful. Again, you don't always see the benefits right away during the treatment, but studies that have looked at patients who have gotten this treatment tend to do better 3 or 6 months later than patients who don't get that treatment. After these acute treatments, subsequent treatment really depends on what the underlying cause of the optic neuritis is. So if it is multiple sclerosis, there are different medications that are changing all the time that we're using for multiple sclerosis. Whereas patients who have NMO, now we have lots of therapeutic options that are more specific for that disease. There are certain diseases like MOG-associated disease where the treatment is still evolving. And a lot of these treatments work in similar ways, with the main goal of reducing the immune system's tendency to attack the myelin or the insulation of the nerves. So what about recovery and the chance that it's going to happen again? So in most patients, vision starts to improve within weeks, and it can take several months for the complete recovery to occur. This is one of the things that I often emphasize with our resident doctors and our medical students, that just because a patient doesn't improve while you're giving them the acute treatment doesn't mean that treatment is not going to help them. Sometimes it takes several weeks or months for the patients to see that benefit. This is also something that I share with patients who are understandably concerned that they're not recovering fast enough. There are some patients who start to see improvement more quickly, and unfortunately, there are some patients who don't see much improvement even with these aggressive treatments. In general, the more severe the symptoms are to begin with, the less likely the patient is to have a full recovery. But it is still possible, and I have definitely had patients who had complete loss of vision who still recovered significantly. There are other factors that can play into it, including the age of the patient, gender, ancestry, access to care. But there's a wide range, and it's very hard to predict in a given patient. Generally speaking, NMO tends to recover less well than MS or MOG-associated disease. But again, even with NMO, there are variations from patient to patient. In general, recurrence is a very big risk with NMO unless patients are treated to prevent that. So this is why we emphasize getting on a preventive treatment very early on, even while we're still doing the acute treatments. Multiple sclerosis and MOG-associated disease have an increased risk of recurrence, but it's not quite at the same level as NMO. Nonetheless, it is fairly standard to start patients on treatment to help prevent further relapses for both those diseases. The exception potentially for MOG-associated diseases in children who have a very good recovery. We have newer therapies, as I mentioned, and these have drastically changed the risk for recurrence. So thankfully, what was previously an almost certain recurrence with NMO, either in the optic nerve or in the spinal cord, now we have very good treatments that can help prevent that. And we're doing a lot of work to try to get patients with optic neuritis free of relapses so that they can recover their vision and maintain their function for as long as possible. That is all I had to say before the question and answer session. Hopefully I've given an overview of optic neuritis that makes sense and to help frame this syndrome for you. And now I would be happy to field questions if anyone has them.
Hi, everyone. Thanks, Dr. Cho, for being here. If you guys don't know, Dr. Cho was actually my first NMO doctor, so this is very special to me. I encourage you all to ask him questions, submit your questions in the Q&A section of this webinar. And Dr. Cho, I guess I'll start and ask a question to get things started. If you have lost vision as a patient, what are the chances that you would recover that if you have optic neuritis?
That's a great question, Sumaira. So the question is, what if you have optic neuritis and lost vision, what are your chances of recovery? It's really hard to predict patient to patient. Almost all patients will have some recovery of vision. And that, I think, is a very hopeful and reassuring fact. It really depends on a number of factors. One is how severe the vision loss is to begin with, which makes sense. The more severe the symptom is, typically the more severe the inflammation and injury to the nerve are. Second is how quickly do you start treatment for that inflammation? Third is what is the underlying cause and how destructive is that cause? So there are differences there between NMO and MS, for instance, where NMO tends to be a little more inflammatory and destructive compared to MS. And then time really is the only way to know how much recovery there will be. So I'm sorry if I sound like I'm hedging on the answer, but there's a number of factors that go into it. But I would emphasize that almost all patients have some improvement. Are there other questions?
we get other questions, I guess I'll ask another one. What are, besides steroids and the immune suppressive therapy that's currently available, is there anything else in the pipeline right now for optic neuritis and specifically for the NMO and MOG community that you can share? Or
So, Sumaira, before I answer that question, I see another question that popped up in the
go for it.
Message related to your first question.
Okay.
So what time frame would you use for your window of recovery of vision with optic neuritis? Most patients will have recovery over a period of several weeks. Some patients start to see improvement within days of initial treatment, and some patients take several months to get full recovery. It really depends, again, on the severity of the inflammation and how much repair needs to happen with the myelin. I have had patients who continue to recover for up to 6 months or more. So if you're not having the full recovery that you want and it's only been 3 to 6 months, there's still hope that you'll continue to have improvement there. Getting to your question, Sumaira, about any treatments that are in the pipeline specifically for optic neuritis or for NMO, I'm not aware of, so the disease treatments that would be specific for optic neuritis might target the optic nerve pathology specifically, but what we know about NMO and the way it affects the optic nerve is very similar to how it affects the spinal cord or the brainstem. So the nature of the injury at the molecular level or at the level of where the myelin is being injured is very similar. So there would not necessarily be a different treatment target for optic nerve versus spinal cord. So all of the immune therapies that are being developed in general for NMO would also apply for optic neuritis. I think one thing that might change as we get more and more therapies for NMO is the use of these medicines even before you have a diagnosis of NMO. I like to think of it as shooting first and asking questions later when there is blindness at risk or permanent damage to the spinal cord at risk. So just like plasma exchange is something that specifically helps NMO, we often use it even if the ultimate diagnosis isn't NMO. So I don't have a specific pipeline special targeted treatment in mind. I would say all of the developing immune therapies that are getting more and more targeted will also help optic neuritis, regardless of whether it's due to NMO or not. I see some other questions popping up, and I'll try to get to these in order as I can. I think the next question was a patient who had optic neuritis in 2010 in the right eye, mostly recovered without medications, some numbness on the same side in the jaw in 2020. Diagnosed with seronegative NMO, MOG was negative. Is it possible that the disease has been present for 10 years? Great question. It's hard to know. Numbness on the jaw is much less specific a symptom than optic neuritis. It definitely can happen. And there definitely are patients who have a 10-year gap between occurrences. So I guess I would say, without knowing the specifics of your case, it's hard to know for sure how definitive that diagnosis is. In general, when we're not sure, sometimes we label someone as having seronegative NMO because the stakes are so high if you don't treat it and it comes back and affects your other eye or your spinal cord. Another question, I have had NMO for 32 years. I'm nearly totally blind since 16 months after the first symptoms. When I had a pseudo relapse, I asked my doctor if they would treat with IV steroids if I developed optic neuritis. They said they would not because I wouldn't have much loss of vision. Should I be treated with IV steroids if I develop optic neuritis? So I think so. Pseudoflare is a big issue and can be a challenge to differentiate. The pseudoflare is when patients have worsening symptoms that are not due to actual inflammation, but rather something else that's irritating the scar from a prior inflammation. So steroids don't generally help that type of symptom. That pseudoflares are common when it's hot or someone gets sick. I think it can be tricky. What I usually do when I'm not sure whether someone's having a recurrence, well, first of all, I err on the side of treating, because although steroids do have a lot of side effects and we don't want to give them without good reason, the quicker you treat, the better the response is. I will generally get some help from neuro-ophthalmology and do an MRI with contrast to look for signs of inflammation in the optic nerve to help me decide. Those things are not always available depending on where you live and how close you are to a center that has that capability. So I think if you don't have that option, it's really depends on your doctor and the type of symptoms that you're having to work out a plan together. Next question regarding MOG, is there any data associated to the COVID vaccine and relapse possibilities? That is a hot question. A lot of patients have this question, not just with MOG, but with NMO and MS as well. The short answer is no. We don't have any specific data that suggests a specific risk for relapse with getting vaccinated. I know this is a very controversial topic, and we're still trying to collect information. There is a registry for MS, which is a more common disease, and so there's just more patients around who are getting vaccinated. There definitely is a theoretical risk that anything that stimulates the immune system could ramp up a disease like MOG or NMO or MS. However, getting COVID has that same risk and maybe worse because of the other effects that the actual virus could have. So it's while there's not a lot of settled data or science to tell us exactly what that risk is, I think it's fairly black and white that the overall risk from getting COVID outweighs the risks of side effects from the vaccine. And all of our NMO and MS experts generally are in agreement that the vaccine is recommended. Some of that risk may also be affected by whether you're on treatment for MOG or for NMO, which should also help protect you from any side effects related to that. Next question. Does it always start in your eyes? So optic neuritis definitely starts in the eyes by definition. NMO does not always start with optic neuritis and may first present with other symptoms such as weakness or numbness or trouble with your bathroom functions related to spinal cord inflammation, or even to involvement of the brainstem with symptoms like vomiting. So it depends on the nature of your disease where it starts. Optic neuritis is specific inflammation of the optic nerve, so it's always going to involve the eye. Can you have optic neuritis not due to NMO, MOG, or MS? Absolutely. So MS is the most common disease associated with optic neuritis. Obviously, NMO, it's a core feature, and it's very common with MOG as well. There are patients who have optic neuritis who don't have any other signs of MS or NMO or MOG and whose antibodies are negative, and they may never go on to have another episode of optic neuritis again. This is where it gets tricky with determining when to start someone on preventive treatment if those tests are all negative. So when we don't have an explanation for a syndrome, we use the term idiopathic. That just means no disease identified. And idiopathic optic neuritis is actually fairly common. And so a large number of patients with optic neuritis will have no other disease identified. We don't really understand why that happens. It could be a mild form of one of the other diseases that doesn't ever reach the point where you detect antibodies or develop other symptoms, or it could be totally unrelated and just a fluke thing. So whenever I have a patient with optic neuritis, I'm very careful to keep a track of them, keep an eye on them, so to speak. Sorry, Sumaira, for the pun. She's used to my bad puns. To make sure that they don't develop new symptoms or even new changes on their MRI scan without even having symptoms. The farther you go after having optic neuritis without any other symptoms, the less likely it is that it's due to one of these diseases. So after a period of several years, I sometimes stop checking MRIs and just have patients call me if they have new symptoms. All right. Can optic neuritis recur in an eye which has already been impacted and blind? That's an excellent question. In general, optic neuritis can occur in any eye. Obviously, if vision has not recovered, it would be harder to know that you have a recurrence because vision is one of the main symptoms. So patients might have pain in that eye with eye movements that's typical of optic neuritis. A lot of times the pain, it's variable how much the pain is bothersome. For some patients, the pain is quite prominent. And even if there's no vision change, it's something that you want to treat aggressively. In others, the pain is mild and the main problem is the vision loss. So if the eye has already been affected by vision loss from optic neuritis, and the only symptom is pain, it really depends on the level of how severe the pain is, whether it needs to be treated acutely and how aggressively. Okay. So a patient currently without eye symptoms but unable to walk with limited use of the right arm. What type of therapy should I be doing to help me walk again, and how aggressive should it be? So whenever there are limitations from inflammation of the central nervous system, such as myelitis, the treatments vary with how long it's been going on and how it's changing over time. So unfortunately, we don't have any medications or other medical treatments that can restore parts of the nervous system that have been damaged, apart from giving time for the myelin to reform and heal. I recommend physical therapy and setting up a rehabilitation program for anyone who has weakness or trouble walking or unsteadiness. Sometimes that starts out as an intensive program going multiple times per week. Eventually, sometimes it becomes once a week, and eventually, patients typically graduate from those programs and are given a set of exercises to do on their own, partly because the insurance coverage often runs out after a certain number of sessions, but also just because the marginal return or benefits from doing the in-person tend to go down over time, and there's just resource limitations. Physical therapists need to be taking on new patients as well. So there's not a specific exercise program. I think if you haven't had physical therapy recently, just having a visit to talk about what is safe and what exercises might best target the muscles that are affected in you would definitely be worthwhile. Another question. My condition has become very constant and slowly getting worse. Is this normal or typical? Slow, steady progression is not the typical path or time course for NMO or MOG, but like any disease, there are exceptions to the rule and at different ends of the spectrum. So without having more information or details, it's hard to know whether it's appropriate to look for other causes or make sure the diagnosis is appropriate or revisit the treatment plan. when I have patients who I think have NMO or I've diagnosed with NMO are progressing, I will often recheck things like an MRI scan to see if there's any other indication that there's ongoing inflammation. Sometimes I'll do a spinal tap. Sometimes I'll have the neuro-ophthalmologist do those tests that I mentioned earlier to look at the function of the optic nerve. If I feel like there's progression, even if it's not typical, if someone has aquaporin 4 antibodies, I will generally treat that as a treatment failure and try to increase the aggressiveness of my treatment for their underlying disease. Other patients may have other explanations for their worsening, so I think you have to really take it on a case-by-case basis. Next question. Has it been determined how NMO starts in the body? Are we born with it? Is it environmental, or can it be developed over time? The short answer is yes to all of those. It is not understood exactly how NMO is triggered, but it is a combination of having a genetic predisposition and exposure to certain things in the environment over time. I generally tell patients that it's really just boils down to bad luck. There's not anything that patients do in terms of their lifestyle that is guaranteed to trigger NMO. And it is not something that's generally passed down the way we think of simple genetic diseases like cystic fibrosis or Huntington's disease, where there's a single gene that gets mutated and that gets passed down. It's much more complex than that. So there's a lot of research going on into this, and there are rare examples of NMO in the same family, and we're trying to use those kinds of rare occurrences to understand it better. So unfortunately, there's not any evidence right now to help guide us as to lifestyle modifications that can help reduce the risk for developing NMO, other than the common sense things like having a healthy diet and exercising. All right, the next question. Is a person going to have another attack? Will it start in your eyes? That's a great question. So for NMO, it varies. Some patients have another attack in the other eye. Some patients have an attack in the spinal cord. There's data that suggests possibly with MOG, it's more likely to recur in the eyes than it is in the spinal cord. The bottom line is, for a given patient, it's really hard to predict. So I generally advise patients to be mindful of any symptoms in the eyes or in their arms and legs in terms of weakness, numbness, or bathroom functions or walking. If they have any concern or questions that something is related, just to let me know. It can be tough to sort out what's a pinched nerve, for instance, from inflammation in the spinal cord. So unfortunately, I don't have a straight answer for you. It can reoccur in the same eye, it can occur in the other eye, or it can occur, a relapse can occur in the spinal cord. Let's see, have you seen patients recover their vision many years after having optic neuritis? So the longest time period where I've seen ongoing improvement is around a year. So there's always variations at the extremes. So the vast majority of patients recover vision over weeks to months. There are some rare patients who have ongoing improvement up to a year later. The exception is if there's some ongoing inflammation that hasn't been treated yet, and then that gets treated before permanent damage has occurred to the nerve. Next question. After 4 months of oral steroids and taper, 2 weeks after being off steroids, I had pain throughout my body. Is this because my cortisol hasn't recovered yet and my body isn't able to control inflammation? Is this common? And this is coming from a patient who's 50 years old. So Regardless of age, anyone who's been on corticosteroids like prednisone for weeks to months can experience a number of symptoms when the steroids are decreased and stopped that may or may not have anything to do with the neuromyelitis optica or MOG or other disease. So your body, you're correct that your body makes cortisol. It's a stress hormone. So when we're playing a sport and we twist our ankle in the middle of the game, sometimes we're able to keep playing because we have this surge of adrenaline and cortisol. It fluctuates during the course of a day. When you're sleeping, it kind of turns off. When you wake up, it turns up a little bit. Whenever you're on prednisone for a long time, your brain sees that prednisone and stops making the natural form called cortisol. And some patients, after they've been on prednisone for a long time, their body's not used to making the cortisol, and it can be tricky to know whether symptoms that happen in that setting are due to not enough cortisol or whether it's something related to the underlying disease. So when I'm not sure, I try to ask about symptoms like fatigue, which is also very common in diseases like NMO, MOG, and MS, but more specifically, trouble with lightheadedness when you stand up. Symptoms like that can be more typical for not having enough cortisol. There's also blood tests that can be done if your doctor is not sure. Sometimes we have to put people back on a very low dose of prednisone just until their body adjusts. Okay. Once the inflammation caused by MOG is gone and you test negative to MOG antibodies years later after the attack, is there any known treatment or treatment in development that may help vision to recover? So there's kind of two questions in there, two issues. Having the MOG antibody turn negative, I think is better than having it stay positive, but it's not truly predictive of whether recurrent attacks are going to happen and whether someone needs to stay on treatment. The converse is true, that some patients who have a persistent antibody for MOG never have another recurrence. Aquaporin 4 patients, we don't typically follow the titer routinely because it's not a great predictor for whether someone is going to have recurrence, and we just assume everyone with aquaporin 4 is going to recur if they're not on treatment. So the presence of that antibody or not, I don't think has a significant impact on vision recovery. Unfortunately, it's just time. So if it's been years without vision change, it's less likely for there to be improvement than in the first weeks to months after an episode of optic neuritis. Is there any data regarding IVIG and vaccines? Does the IVIG dilute the efficacy of vaccines, COVID, and others? That is a great question. Short answer is I'm not sure there's any studies looking at the impact of IVIG. For those who don't know what IVIG is, it is basically thousands of blood donors. The blood is rinsed so that the blood cells are out and it's just a bunch of antibodies. So it's a filtered, cleaned antibodies from thousands of patients who've donated their blood for this, and it's purified. So it contains a ton of antibodies. I'm not sure biologically that it would prevent the COVID vaccine from being effective. It can have some effect on your production of white blood cells, for instance, but unlike other treatments that turn down the immune system, the IVIG works in a different way than, for instance, rituximab or the newer infusion treatments we have for NMO that target B cells or IL-6 or other aspects of the immune system pathways. So I don't think IVIG would prevent someone from having an appropriate response to the COVID vaccine. I certainly don't think it would increase the risk of a COVID vaccine. So I have had a few patients who are on IVIG, and I've recommended that they get vaccinated. I generally, just to avoid any confusion about a reaction, I recommend they do it in the middle of their cycle, not at the same time that they're getting the IVIG infused. Another patient is getting referred for further evaluation. They told they had NMO in the hospital in March. No tests or spinal fluid coming back to confirm. No MOG. High inflammatory markers. Color and vision loss for months now. Is the myelin around the optic nerve that is inflamed? There have been 4 MRIs, IV steroids on mycophenolate, which is Cellcept, and hydroxychloroquine, which is Plaquenil, now off steroid taper. Also getting vitamin B injections for extreme fatigue. Lower limb and foot spasms. So it sounds like there's a lot going on, and that you may well have a syndrome that could be compatible with NMO. Not every patient who has NMO has positive antibodies. We don't know whether some of those patients might just develop the antibodies later, or they have a different disease that looks very similar to NMO that we just don't understand or have a test for yet. So I think it sounds like you're on a reasonable treatment to try to prevent recurrences, but if you're still having ongoing symptoms, that might be something to revisit with your doctors about whether other infusion treatments for NMO might be appropriate. Next question. If you had a patient with confirmed aquaporin for NMO and they were nearly totally blind, only seeing gray, and their MRI showed inflammation due to optic neuritis, would you treat the optic neuritis with IV steroids? So similar to some prior questions, I think it really is patient and provider dependent. And as a doctor, I try to balance the risks of a treatment with the potential benefit. So I would say if the vision that the patient has before the recurrence allows them to have added functioning in their life and it's important to their functioning, then yes, I would try to preserve every last bit of it that I could with steroids or other treatments. If the patient has such impaired vision that the amount of shadows that they see doesn't really help them, or if the patient hates the side effects of steroids and really doesn't want to do that treatment, then I would defer to the patient and their decision making on that. So it's kind of a gray zone. Sorry again about the pun. I forgot to put in a question. So Sumaira, do you know if this was the same question regarding the symptoms with the referral?
Yes.
So yes, those symptoms, it sounds like you may have had optic neuritis and you're also having symptoms in your arm or leg. Definitely could be compatible with NMO, but not necessarily the only possibility. So, we don't have an antibody test for MS, for instance, and it's based on a number of things like the MRI pattern and ruling out things like NMO and MOG. But even when we do all that testing and we don't think it's MS, we don't think it's NMO, and we don't think it's MOG, sometimes we still treat patients even if we don't have a specific diagnosis, just because the nervous system doesn't always recover fully. So we want to be on top of it as much as we can, even if we're not sure the final diagnosis yet. So I do think it's appropriate that you're getting referred and evaluated for that possibility.
All right, and I get the last question. I'm not your patient anymore, but am I still your favorite?
There is only one right answer to that question.
Thanks, Dr. Cho, for being here. Your answers were incredible. I know that it was well received by all of the patients here and the caregivers. And thank you to everybody who asked so many thoughtful questions. The session is recorded and we're going to put it on Facebook and YouTube so you can access it later. Dr. Cho, thank you so much. And everyone have a wonderful day.
Thanks for inviting me.